Our next speaker, Dr. Shreesh Kumar, who is the medical superintendent of the Eye Foundation group of hospitals, and he's going to be talking on DALC, choosing the right technique for the right case. On to you. Thanks, Dr. Geeta. Thank you very much. Thanks for everything. Support through. Thank you.
My talk is on DALC, the right technique for the right case, preferred practice guidelines. We all know keratoconus is one of the commonest indication for DALC, and these are some of the
6
indications.
minutes. It's written as
Some of the
fine.
indications for keratoplasty in keratoconus. I'm not going into the details of these. These are the preferred surgical techniques. The preferred surgical technique is the big bubble technique, which was described by Anwar and Tikman, and manual layer by layer technique is the fallback technique. We should know this technique. Whenever there is a complication, we can always go back and continue with the DALC using this technique. So whenever we inject air bubble into the stroma, we get one of these three types of bubbles: type 1, type 2, and type 3 bubble. Type 1 bubble is also called white margin bubble. It is a strong bubble, and whenever you get a type 1 bubble, the chances of perforation is less. And this is the type 2 bubble. You can see a thin margin bubble, or it's a clear margin bubble. The chances of perforation with type 2 bubble is maximum. And type 3 bubble is a mixture of type 1 and type 2 bubble, and the perforation chances are more with the type 2 and type 3 bubbles. And this is a demonstration of type 1 bubble. You can see it's a white margin bubble, and the floor of this bubble, it contains Duva's layer as well as Descemet's layer and endothelium, and the thickness is around 30 microns, and it's a strong bubble. The chances of perforation is less with this. And you can even inject air bubble into the antechamber to make sure that your bubble is formed, which the bubble, it displaces the bubble in the antechamber to the periphery. So it's a clear indication that there is a nice bubble which is formed. This is just a few cases. This is one particular case with the visual acuity of 6 by 60, 12 years old boy, and this is the topography of the patient. Thinnest corneal thickness is 271 and high astigmatism. This is a clear-cut case of DALC. It's an indication for DALC. And this is how I do, and it's actually a big bubble, and I usually do a superficial lamellar keratectomy initially, and then collapse the bubble using a 11 number blade, and then inject visco into the neck incision to keep the Descemet's away from all the manipulations. I use a blunt tipped venous scissor to cut the posterior lamella into 4 or 5 segments, and till the periphery, and then I prepare my donor's tissue and place the graft on the host and suture it. I usually put 16 interrupted sutures if the size of the graft is more than 8 millimeters. If it is less than 8 millimeters, I usually put 12 sutures. And coming to type 2 bubble, we should know the types of bubbles, and clearly, and accordingly you can change your surgical plan. And this is a nice big bubble which is around 10 millimeters in size, diameter, and you should identify this if at all you get this during surgery. And there is a classification based on OCT. It's a thorough preoperative evaluation of these patients, slit lamp evaluation as well as OCT evaluation has to be done to identify the stage of the condition. The keratoconus is divided into 5 stages, and the up to 3A, stage 3A. Stage 3A is like there is epithelial thickening and stromal thinning. There is no opacification as such in the stroma. So up to 3A, you can safely go ahead and do a big bubble DALC. and beyond that 3B onwards, that is 5A, 5B is, that is acute hydrops, and 5B is healed hydrops. These are the stages wherein it's very difficult to get a type 1 bubble, and you end up with a type 2 bubble. In such cases, you have to go ahead with the manual DALK. And this is our publication, the complications in deep anterior lamellar keratoplasty, which was published last year. We also found that the perforation is more common with the type 2 bubble and the type 3 bubble. And another publication recently, this year, it was published in OJO, it's from our center only. And again, the perforation is more common with the type 3 bubble and type 2 bubbles. And those who are having a deep stromal scar, the chances of perforation is more. A case of scarred cornea. This is a case of advanced keratoconus, and you have a deep scar extending up to the posterior stroma. And this is a case for DALK. Of course, one should be very careful while doing DALK in this particular case. This is how it went. You end up getting a type 2 bubble. You carefully observe here, it is a type 2 bubble. You notice this bubble, and then instead of doing a big bubble technique, you go ahead and do a manual technique, so that you can avoid perforation, you can continue with your DALK. So that's what has been done here. The patient ended up with a manual DALK. Another case of healed hydrops. This is a healed hydrops case. This is a OCT picture of the same patient, and a pentacam picture. And I went ahead with the manual DALK in this particular patient. If the scar is paracentral, you can safely go ahead. I usually inject air bubble into the stroma to create emphysema. Actually, of course, this is not advised. Many surgeons won't follow this, but this actually particular technique I am comfortable with. I do a manual DALK. I go right up to the pre-descended layer. These small multiple bubbles, they act as a guide, and I just stop short of these small bubbles, and that suggests I am in the right plane. That is in the pre-descemetic layer. Without perforation, you can continue with the DALK. It is repeatable, and you can do it in all the cases. This is the post-operative picture, day 1 and 6 weeks and 6 months post-operative picture. You can see a thin area of opacification around the perforation. This is the pre-operative and post-operative picture of the same patient. And advanced cases with the DM scar, again this is a healed hydrops. This is how it is post-operatively, the DALK. You can see a perforated area here, but it has sealed very well. So DALK can be performed in these cases. In spite of having perforations, you can continue with the DALK. Manual DALK is a savior. You can always learn to do this particular procedure. Conclusion is the surgical management of keratoconus. We have to identify the stage of keratoconus, and then plan either a big bubble DALK or a manual DALK. So this is actually an algorithm for performing DALK, taking advantage of preoperative OCT. If the keratoconus is stage 1, 2 or 3A, you can go ahead with the do a deep trephination, just start of 100 microns from the thinnest peripheral corneal point, and do a big bubble DALK. If that is not possible, then you can go ahead with other techniques like a manual dissection or visco dissection. And if there is intraoperative OCT which is available, it's good. But if you don't have, still you can safely go ahead and do your DALK. Thank you very much.
Thank you, Dr. Shreesh. One very simple question to Dr. Revati. Post-operatively, the patient has a double anterior chamber. So what would you do immediately?
Yeah, usually we used to warn them also before surgery. You may need immediately also few settings, and Unless it is a very shallow double anterior chamber, we are sure we'll wait if there is no perforation. But otherwise, it's better to go in and do a air bubbling, and observe, because this case is advanced. And yesterday, Dr. Vanati, I think, mentioned better to go for a 0.5 larger graft, as in the regular PKP, than the same sex graft or less, because that will also reduce this chance for double AC without perforation.
Do most of these challenges get obviated, Dr. Vanati, with an IOCT?
I think an IOCT is an added advantage, especially if you are probably assisting your residents and fellows in a training program. It helps to minimize the intraoperative events here. That's it, and I think we all trained without the availability of an IOCT. So we are still adept at doing the same whenever we are doing it.
Okay.